So welcome to my channel. So today we're going to discuss about special test for shoulder joint. So what are the tests we first do? First one is the anti-instability test. So why we do anti-instability test? Because of we have to differentiate the ligament and capsule laxity from the other condition. So there is three main tests. First one is load and shift test, then second one is the crank and apprehension test, and third one is the relocation test. So for load and shift test, we have a patient sit with no back support, arm rest on the thigh. Therapist stand behind the patient and stabilize the shoulder on one hand, and other hand grabs the head of the humerus, thumb on posterior shoulder, and finger in the anterior shoulder. Then examiner push the humerus head anterior for anterior instability test and posterior for posterior instability. So 25% laxity is normal. If it grade 1 ligament injury, then there is 25 to 50% ligament laxity. If they are humerus riding up to the glenoid, and if grade 2, then humerus head overriding the rim, but more than 50%. And if grade 3, a feeling of humeral head overriding the rim but not reduced spontaneously, more than 50%. Then for second one is the crank and apprehension test. So for that, we can do this test because of to differentiate the inferior glenohumeral ligament from other condition. So patient is either sitting or supine, shoulder in 90 degree of abduction, and elbow is flexed. The therapist one hand hold the patient wrist and slowly abduct 90 degree, then external rotate to 90 degree. If patient express pain apprehension, then test is positive. It also indicates recurrent dislocation of shoulder. Then for relocation test is same as crank test, but only therapist other hand and shoulder, then therapist apply posterior stress. Then patient having less apprehension and pain, and further external rotation before apprehension come. Then for posterior instability also we have to test load and shift and posterior apprehension. Load and shift is same in anterior apprehension, anterior load and shift. And for posterior apprehension, patient is supine, 90 degree flex the shoulder, elbow, and internal rotated. Examiner grabs one elbow in one hand and stabilize shoulder in other hand. Apply force on the long axis of humerus. Then positive test indicate apprehension to prevent and shoulder dislocation posteriorly. And if positive test indicate laxity in posterior capsule or the posterior ligament. Then for inferior instability, you have two tests. One is sulcus sign, another is Fagan sign. So for sulcus sign, patient sit or stand with involved arm hanging at the side. Examiner stabilize the shoulder on one hand, grasp the lateral arm on the other hand. So mode is to apply downward direction of distraction force. Positive test indicates sulcus seen just lateral to the acromion, which indicate the inferior dislocation or subluxation of the shoulder compared to both sides. Then for Fagan's test, it also called abduction inferior instability test. So patient sit or stand with shoulder abducted 90 degree, elbow extension, arm resting on the therapist's shoulder, and the therapist interlock his both hand and apply downward force over the deltoid. If test is positive, then watch apprehension, which indicate humeral head inferior subluxation. Then for labral lesion, I have mainly four tests. One is Klunk test, anti-slide test, O'Brien's test, and pain provocation test. So for Klunk test, patient position supine, glenohumeral joint slightly over the edge of the table, and one hand of the examiner on the posterior shoulder, another on the posterior elbow. Examiner rotate the arm externally and internally in the abducted position and feel some popping, clucking sound. Then pain test is positive and some labral tear is happening. And for anter's slide test, patient standing hand on hip, thumb pointing posteriorly and acromion, while other hand apply force on the elbow and humeral head anterior superiorly. And if positive test indicate popping, clucking sound. Then for O'Brien's test, patient sit on the table, forward flexion to 90 degree, abduction to 10 degree, and internal rotation, thumb down. And examiner push down on forearm with patient resting. Positive test indicate patient increase pain with external rotation of palm up. If it is superficial pain, then it can indicate acromioclavicle joint problem, and if deep pain, then there is labral tear. Then next for pain provocation test. So for pain provocation test, patient sitting with other arm 90 to 100 degree of abduction and the arm is maximally external rotated and forearm is excessively pronated or supinated, and the therapist one hand above the shoulder and other holding the chest. So when pain is more severe in pronated position, then the test is positive. Then for scapular instability, we have lateral scapular slide test. So arm at the side, uh, uh, shoulder 10-degree extended, 90-degree elevated with internal rotated. So measure a distance from one fixed bony point to both the inferior angle of scapula. If 1.5 centimeter, it consider normal. If it more than, then there is an instability present over there. Then for biceps tendinitis, we have three tests, mainly speed test, Jagarson's test, and Ludington's test. So for speed test, patient sitting or standing with the shoulder flexed to 90-degree, elbow is fully extended and forearm supinated. And therapist one hand on patient forearm and other on the bicipital groove. So examiner resists the patient to flex further. Then positive test indicate pain and tenderness on bicipital groove, which indicate bicipital tendinitis. Then for Eggerson's test, patient sitting or standing with elbow flexed to 90-degree, so a lateral border of radius face upward, and therapist place one hand on the patient forearm and other near the bicipital groove. Then resist the supination. So if during supination a patient having pain on the bicipital groove, then test is positive. Then for loading distance test, arm raised by the patient and hand clasped on the top of his head, and patient attempt to contract and relax alternatively the biceps. Then examiner palpate the biceps. If test is positive, tendon not felt, which indicate long head of the biceps tear. Thank you.